Hello, welcome back to Resilient Aging Unfiltered. Today we have an amazing guest. This is sure to be a fantastic conversation. Today I'm so lucky to be joined by James Hosobe. Thanks for being here today, James.
Thank you for having me, Dr. Cabral.
We're going to talk about a really exciting and sometimes controversial topic, which is psychedelics, and specifically for therapeutic use, and hoping to go into looking at these for older adults. So I'm just going to tell you all a little bit about James, and then we'll jump right in. All right. So James is a biomedical research analyst at Arizona's Department of Health Services with experience in preclinical and clinical trials and psychedelic policy. He holds degrees in biochemistry with an emphasis in medicinal chemistry, East Asian studies, and pharmaceutical sciences. What a great mix. James has also contributed to state initiatives involving psilocybin and ibogaine. His work focuses on drug safety, harm reduction, and psychoactive pharmacology and evidence-based regulation. Amazing. And so James and I met while I was supporting the Arizona Psilocybin Research Advisory Council, which that wrapped up this year. So thank you again for being here and for what you do.
Thank you. An awesome introduction. I appreciate that. Yeah, we first met at the Psilocybin Research Council.
Yeah. And, Arizona's just starting out in this world. And there's a lot of states that are much farther along. So why would you say psychedelics are generating so much excitement now in medicine?
Yeah, that's a great question. So I would say psychedelics are getting a lot of excitement through the general public because unlike most psychiatric medications, that usually typically require like daily dosing. A lot of psychedelic compounds have this potential benefit to have lasting effects for weeks into months after 1 or 2 doses with supervised sessions. And so they might really represent an entirely new therapeutic paradigm that is completely different from your traditional SSRI.
Yeah, great. That's so needed. And so I use the word durable effects. And so I reached out to James after some of my patients contacted me when there was recently this press about a woman who had severe cognitive and functional impairment due to, Alzheimer's disease or something similar disease, had been given psilocybin and had what sounds like some kind of miraculous turnaround.
Mm-hmm.
And now this was a case report. These things have come up over the years, and it's, of course, open label. Everyone knows that she's getting the active medication. There's a lot of challenges with drawing any interpretations from that. But the point is, several patients and family members reached out to me. Can we do this? She, I think, was given a larger dose, but people, of course, often talk about microdosing. So there's so many things we don't know. And I wanted to this is, just a first conversation to start this, but how do we actually determine if a psychedelic is effective versus simply producing some kind of spiritual experience?
That's a wonderful question. I think before I can answer that, I feel like laying the groundwork of actually defining what a psychedelic is important. And it's a very controversial topic in the field. I am of the camp of being a pharmacological purist, and I feel like drugs should be classified based off of their mechanism of action. Sure, you can talk about the phenomenology or the subjective effects, but when it comes to policy and science, we need to be really important and careful of how we classify certain psychoactive substances. So for instance, with psychedelia, or psychedelics, they are very interesting, unique compounds ranging from psilocybin, as you'd previously mentioned, LSD and DMT, and you can even throw in mescaline from the peyote or San Pedro cactus. And what's unique about the psychedelic drug class is they are 5-HT2A agonists. They work on the serotonergic system. And many caveats would say, well, there are millions or hundreds of thousands of 5-HT2A agonists. Well, what makes psychedelics really unique is not only do they agonize the serotonergic system, but they also offer a complete change in your overall state of consciousness. Some people would say that there are hallucinations, whether it's visual or audio, and it can completely restructure and change the way the brain is active in a sober state. And so when you talk about compounds that are psychedelic adjacent, like let's say ketamine or MDMA, being a dissociative anesthetic and an empathogen and a tactogen, respectively. You could have similar treatment modalities as far as the psychotherapy goes, with good therapeutic alliance and making sure the set and settings are appropriate. But in regards, though, to classical psychedelics, I think that they show remarkable efficacy.
Great. Thank you for laying that groundwork. And there was a ton there that you brought up. And in thinking about how do you bring together, there's multiple forces here at play that lead to therapeutic effect. And we're trying to fit them into our, more Western medicine research pathway. And so how have you seen that done well, I guess, and what are the main things we know, things we've learned not to do?
Mm-hmm.
And these might be really difficult questions to answer because there's so many different compounds and they're doing different things. But if you could try to generalize.
Certainly. So yeah, there's a couple big questions in the field, especially just answering how do they truly work? Unfortunately, with the Controlled Substances Act being Schedule I substances, it really pushes back the research that is allowed on these compounds. And it's unfortunate because having a Schedule I status essentially means there's no medical benefit. But as we can tell with the recent cannabis and, having prescription Dronabinol for cachexia or appetite stimulation in cancer patients, we definitely see a hypocrisy when it comes to certain substances on that scheduled list. And so I call for a in-depth restructuring to make it more scientifically sound. But when it comes to some of the challenges, right, a lot of people will say that psychedelic compounds have been used for thousands of years, many by the indigenous peoples in South America with ayahuasca, or even peyote in sweat lodges for the Native American church. And so you had asked, how can we fit this into a Western medicalized model? And I will say adopting traditional indigenous practices into our Americanized medicine is impossible. The FDA through clinical trials would never allow outside tripping. There's just too much variables that could happen that could potentially danger the individual. And so another challenge that many talk about is dosing protocols. How much is it too much? What is a good tapering, especially if there are many that have indications like depression or anxiety? More likely than not, they're on a SSRI, SNRI, etc. And so how can we properly taper an individual off of an antidepressant to prep them for a clinical trial of a classical psychedelic? And then lastly, I would say, who's even qualified to be in the room? Who's allowed to actually guide an individual through something so intense and profound? And for those who have not had the, experiences of utilizing a psychedelic, many in the literature state that they're ineffable, they're indescribable. And there's a John Hopkins by Roland Griffiths paper who said one of their clients had said, it was of the top 3 most influential experiences of my life, right next to marriage and my child's birth.
Well, yeah, it's the way, when you just were talking, the way I was thinking about it was it's not the substance or the medication or the compound, it's the experience. And we really have a hard time capturing that or seeing value in that or being able to disentangle. We want to, reduce it all. Yet, like you said at the beginning, this could be really much more cost effective to be able to have one or two of these experiences and then have a shift in a way that's meaningful, for the rest of one's life. And so I just need to say, I'm not encouraging people to go out and do any kind of psychedelics without, proper understanding and knowledge and guidance. But it does present a real challenge. And I think about how, and I'm wondering what you think about this. So I know that it seems like, that we have industry, we have companies that are developing compounds, and some of which are intended to, from what I understand, remove that what's the word, that kind
Like
of the spiritual experience and just have it be quietly happening, so to speak, and rewiring the brain. But it seems like you're removing that experience is going to fundamentally remove the therapeutic nature of that compound and turn it into like any other medication. So I don't know, but maybe not. But maybe it'll still work. However, there's a cost incentive revenue generating potential if you have someone taking something that they will continue to take on and on and on versus taking it, once or twice every time. So yeah, how do you respond to all that?
Well, that's a wonderful question. And correct me if I'm wrong, but I think, are you referring to like David Olson's work at Davis, creating like psychedelic, or I guess the coined term is non-psychedelic psychedelics, where
Yeah,
there are
exactly.
very little hallucination effects. However, it agonizes similar receptors. This is my take on it, because a lot of individuals in the psychedelic community, whether it's hardcore advocates, psychonauts, or researchers, many people are very married or subscribe to the trip and the experience as the healing process.
Mm-hmm.
My take on it is I really don't care. I believe in a free market, and if you can create a non-psychedelic hallucinogen with a LSD or psilocybin backbone and it helps people, then great. We need to expand the mental healthcare toolbox. And by any means necessary, I'm all for it. But here's the thing though, and here's the catch, is as awesome as the data is coming out with serotonergic psychedelics, they're not for everybody. Mm-hmm. They can actually make certain people worse, depending upon family history, and even going over the individuals that won't qualify are a really interesting cohort of individuals to research, fearful of maybe suicidal ideation or personality disorders, or even psychotic medications and that potential drug-to-drug interaction. Mm-hmm. But yeah, to answer your question, though, I'm all about opening the toolbox for various indications. And you were right, though, about the revenue generation, because, it might put a thorn in some of these SSRI companies who, love the daily prescription versus the, you do one trip every once a quarter, so 4 times a year. But how is that going to be embedded into the insurance? And, just a lot of questions in that realm.
Okay. Yeah. Can you just, since you mentioned it, elaborate on the groups that these compounds could make things worse or cause adverse effects?
Certainly. Yeah. So right now, cohorts that clients that usually get the thumbs down for a lot of these clinical trials might have indications of maybe psychosis. So depending upon the severity of suicidal ideation, they might not be allowed in the trial. Just, it makes sense, especially for high acuity SMI or serious mental illness individuals, and those who actually are on high dose of serotonergic SSRIs in fear of serotonin syndrome, which I feel is like a neurologist's worst nightmare. It's a very, very scary episode. And it just is one that, we need to really keep an eye on, because, we see it a lot in the rave community, especially with MDMA. And if they're already on prescription med, their brain will fry and get overheated, and it's just a very scary mess. So, and that's the thing too, is I know that a lot of people in the psychedelic community just say, oh, everybody should, take it just once in their life. But it's really, I would say, not really holding harm reduction to its fullest, because they're really not for everybody. And that's okay. We're all different human beings.
Yeah. I mean, just going back to, there's such a need for good treatments, and people are really desperate. And so they want to find new things and try new things. And this is a very hot topic right now.
Mm-hmm.
I would love to hear how you describe what's actually happening in the brain during a psychedelic experience.
Oh, certainly. So, I would say the most interesting aspect of psychedelics in the brain is the neuroplastic effects. So essentially, in just plain terms, neuroplasticity is the brain's ability to form new connections and reorganizing itself. And so for a lot of indications, especially like with PTSD or depression, major depressive disorder, it's a disease, in my opinion, and I have to give a disclaimer, I'm no psychiatrist. I'm just an independent researcher. But they're diseases of rumination, where you get in this stuck pattern loop. And so what psychedelics can do, which I find interesting, is there's this common metaphor of the snow globe, where you have a snow globe and all the snow settles at the bottom. And what psychedelics can do is shake up that snow globe, where all the snow starts oscillating and the entropy is really high in that. And so psychedelics may have this ability to create a temporary window of opportunity where learned behaviors and changes can actually be better learned after an experience. But as you pointed out, it's not just the drug. I feel like the true healing comes from the integration after and trying to make sense of that experience.
I'm going to push you a little more on the snow
Please.
globe analogy and shaking things up and greater entropy, but like what exactly like are you saying is happening?
Yeah, that's excellent. So Robin Carhart Harris published a paper. It's his Rebus model, and it's just brilliant. There's this photo you can look up online where it shows the placebo arm and it shows this picture of a circle with all these connections. And then it has another photo of a ton of colorful connections. And so I guess the snow globe analogy is really analogous to having the brain communicate with other regions that it normally doesn't interact.
Okay. And how is that measured?
Yeah, fMRI. Yeah,
Okay.
you can do radiographs to
Mhm.
test it.
And is fMRI used typically in psychedelics clinic?
Yeah, there's some certain clinical trials that they'll investigate via fMRI,
Mhm.
PET glucose scans to see where glucose is being eaten up in the brain, depending
Mhm.
upon which brain region you're interested in studying.
Yeah. So if we could shift into these specifically as we're aging, I wanted to mention this quote that I'm sure you've heard that was in I believe the Michael Pollan book, How to Change Your Mind. And he says, I've begun to wonder if perhaps these remarkable molecules might be wasted on the young, that they may have more to offer us later in life after the cement of our mental habits and everyday behaviors has set. So that is a jumping off point. Is there something happening biologically that psychedelics might affect an aging brain differently than a younger brain?
Certainly. I would argue in an aging brain, and you could probably explain this way better than I can, aging affects neurotransmitters, brain connectivity, metabolism, and other types of functions. And we all know that as we get older, more and more medical conditions occur. And so what we know actually of how psychedelics affect the aging or an older brain, we really don't know. And it's actually a big mystery, and more research needs to be pushed on this. When it comes to neurodegenerative disorders like Parkinson's disease or Alzheimer's disease, it's literally the disease of the aging brain. And
Right.
so I would argue that psychedelics would really help individuals maybe overcome with like an anti-inflammatory process, because certain psychedelics can offer that. In addition, there's also, as I had stated before, being able to link with new, I guess, pathways or crosstalk per se,
Mhm.
where if you were to ingest one, certain parts of the brain might be connected, which normally isn't in a sober state. And with that, it actually could potentially be very therapeutic for individuals.
Wow. But so it sounds like we don't have the data. Older adults haven't been in these trials very much.
Mhm.
And I guess that's probably because they tend to, like you said, have more medical issues. There's just more risk of bringing them to.
Yeah. And one thing I would also like to add too is if you look at the cohort of older individuals, maybe 65 plus, there was a lot of stigma surrounding psychedelics during the 60s and 70s. And so with the propaganda, I should say, with anti-psychedelics, there's this negative stigma associated with these types of drugs, whether it's Swiss LSD causes Swiss cheese brain, or you take an acid and you're going to want to jump out of a window because you think you're a bird.
Right.
And so my thought process too is the nocebo effect might come into play, where if an individual already has a negative idea of what these drugs can do and they take it, it actually might be detrimental because there's this already negative stigma associated with the drug itself.
And there have been incidences where people did jump off buildings because they thought they could fly. Well, so there is some basis for this, but it is extremely rare. The hope is with the therapeutic potential, these are very much regulated, monitored, guided experiences, ideally.
Mhm.
Or is it possible that people can find great benefit just going and doing this on their own?
Ooh, I would say, see, I'm all about human safety. And so if you have a Jerry Garcia or Jimi Hendrix who has years of experience tripping, then maybe so. But I'm kind of against the tripping alone, just for the potential risks associated with it. And not to mention, if somebody is on a journey, it's always good to have an individual there to keep you grounded and to guide and to be there as a comforting support. Because I really feel as if this drug class of classical psychedelics is really about community and the human experience. And so, yeah, I'm always a safety first is my go-to mantra.
Yeah. Well, often these studies are on psychedelic-assisted psychotherapy. So the psychotherapy is presented as the key feature supported by psychedelics, which changes the whole experience or can create new opportunities, I guess, or you could explain that better than me. But the therapist or the guide is crucial during and after an integration and maybe even before preparation. People, from what I understand, can have significantly different experiences, including for things like the adjacent compounds like ketamine and things like that, which is used widely and is also a lot of companies are capitalizing on this in clinics, and it's mostly pay out of pocket. So it's I guess I'm bringing up a number of things, but including, you really want to know what you're getting into and you have a reputable, high quality group and guides and things like that.
Yeah, I couldn't agree more. And I wanted to bring up for the listeners here who aren't really familiarized with psychedelic-assisted psychotherapy, there's a common, I guess, rule of thumb where many practitioners abide by the set and setting model, where the set is the mindset of the client before going into the trip, because you don't want to put an individual through a psychedelic experience if a loved one just passed or they're filing for bankruptcy or etc. They want to be in a good mindset prior. And then the setting, which I'm very curious about, because during my grad school experiences at the University of Wisconsin-Madison, I had the pleasure of assisting with developing the playlist for their phase 3 clinical trial. And I believe that the music is such an important variable when it comes to this type of treatment modality.
Yeah. Wow. So how did you come up with the playlist?
Yeah, that's a great question. So it was definitely a team effort. I was with the clinical ops team and I took a look at their phase 2 clinical trial playlist. It was good. And here's the thing is I told them from the get-go, some people are going to love it and some people are going to hate it. Music is so personal and individualized. And if I showed one piece of music to one individual, it might bring them bliss and tears to their eyes of happiness. And I show that same song to another and they might just get irritated, angry, or perturbed. And and so it's definitely a tricky challenge. I'm not for the standardized playlist because it's so individualized. I feel like customized playlists for the individual is imperative for a therapeutic outcome.
So is that a function? So incorporating music. So what I think of is helping to regulate the nervous system, and that could be different things for different people beyond music. So I think of nature, animals, or pets, for example. Maybe like gentle touch. So why not customize it to that degree?
Well, I couldn't agree more. Yeah, I was thinking very narrow-minded when it comes to the customization of the playlist.
That's what's used, right? That's
but
commonly in the same playlist, right? For certain trials. Like that that could be like hell.
Oh, certainly.
Yeah.
And it's such a double-edged sword to your point because the FDA, through the Western scientific model, we're all about reproducibility. And so they try to eliminate as much variables as possible. But the problem with that is I would argue you have a different therapist, it's going to be a different trip. And so it's very difficult to have honest, reproducible studies in these clinical trials. Not only with, the setting of who's there, the tactile touch or the soft touch or the felt blankets, because the typical paradigm is they'll give you a headset, they'll give you a blinding eye mask and maybe like a weighted blanket and you lay on a couch. And so it's really difficult to standardize something that is so not only ineffable, but unpredictable. People just, you just don't know until it actually is occurring.
Yeah. There is a hypocrisy in medicine. So, I use this example, which physical therapy is really important and really helps a lot of people and has helped me included. But the way we refer everyone out for physical therapy for everything. And most of this does not have good research backing. And there's pretty much, it seems like free reign for the physical therapist to choose the path, the program and how many weeks. And yes, it's, monitored by insurance, but like usually it's approved and the doctor signs off and they just, and there's an end date for most people. But my point is there's a lot of flexibility allowed there, for physical therapists, and good for them. And talk about like a moneymaker. Wow. Those are the biggest claims in healthcare. Some of them. So no disrespect. I love you, physical therapists. I'm going to keep referring to you like every week, but it's too bad that in all of these other areas, for example, in my field with brain aging, these ancillary therapies are not covered because we can't systematically aggregate the data because everyone has their own little, when they're studying it, their program's a little different and how they do it. And so that means that it's, we can't say for sure that it works. So it's really, yeah, it's frustrating. Thanks for my soapbox. Thanks for listening.
So I'm always here.
I want to make sure I go back to, so you brought up this question of whether in older adults, psychedelics could address in some way inflammation or neuroinflammation. Can you speak more to that, how that works, which of the...
Of course, yeah. So with the classical psychedelics, like either psilocybin, LSD, or DMT, there's some animal studies to suggest some anti-inflammatory effects. But I would argue that the human evidence is still limited. And I feel like a broken record here. We need more research. We need more data. And it's an intriguing hypothesis too, because if you increase this anti-inflammatory effect, the downstream effects on the actual therapeutic process of the brain, I honestly believe that it can help a lot of symptoms.
Yes. I mean, I think about this. You're chilling. I use these words. This is what I say. Like, you're chilling the brain out. You're like cooling it off. And then things can just work better because your brain's energy does not have to be devoted to dealing with this inflammation. Even though it's such a vague concept, it's, hard to pin down. But at the same time, this plays a role in midlife too. So addressing things then to allow the orchestra to happen as it needs to is valuable. So, can you speak to this concept of this critical window or critical period?
Yeah, certainly. So this was coined by Dr. Gould Dolan over at Berkeley, UC Berkeley. And the critical period or this window is typically a couple weeks to months after the dosing session. And the exact range and what it represents to the individual varies from person to person. What I find really interesting about it has this unique ability. I think that's where the true magic happens. Because during this critical period, the brain is, in a sense, I don't want to say, it's so cliche to say resetting, because what does that even mean? But what I'm finding, though, is that many people, after an experience, right, their overall, I guess, well-being, and obviously it depends on whether or not they had a good experience during the trip, but I'd argue the stronger that therapeutic alliance was, on top of what's called the mystical experience, where many practitioners use the survey to describe how mystical the experience of the psychedelic trip was. If you have high scores in both, it's been statistically significant to have better therapeutic outcomes. And so when you couple these two together, it's okay, is it the therapy? Is it the drug? Or is it both? And so many people, I would argue that it's leaning more towards integration and therapy, but the psychedelic itself is like the catalyst per se. It helps ramp up and speed charge this therapy.
Got it. And you had mentioned, I'm thinking about timing, and you had mentioned individuals who have just had some kind of major loss maybe shouldn't step toward these yet. However, those who have PTSD tend to gravitate to these modalities because the traditional approach is not working for them. And so I'm just thinking about when we have a major crisis, loss, pain in our lives, it can dramatically change what's happening and how we're walking through the world, like our consciousness, our ability to think, feel. And yes, if you're actively suicidal or homicidal, like, don't do these things. But it seems like there is something happening where there is a critical period that there is maybe more opportunity for growth and transformation if engaging with these experiences with psychedelics versus just, things are going pretty well. Like life is, you're in a good place for a while and you've kind of been, there's no kind of nagging pain that you're needing to address at the moment, or maybe not. Maybe it can be equally therapeutic. What do you think?
Certainly, yeah. Well, what you're touching on reminds me of this concept in psychedelic neuroscience called the default mode network. And essentially, in simple terms, the default mode network is kind of our autopilot or our internal narrator mode. And the best way to achieve the default mode network is when you're spacing. You're like looking at the wall. If you got 10 minutes left of work and you're just trying to waste time, or at the DMV. The default mode network is up there. And so when you're talking about this critical period, I feel like psychedelics temporarily reduce the activity and actually makes the default mode network non-standard. In other words, it creates this sense of stability of the self, but allows people to become unstuck from this repeatedly reinforced negative thoughts of self-criticism. And many that suffer from PTSD, like you can take the indication of PTSD with MDMA. And I know that MAPS was really close in achieving the approval process for that. And so, yeah, I think a lot of these substances have the ability to help individuals with some of these more ruminating indications. But to your point, though, instead of looking, for me at least, instead of looking at like one compound, I will flip the script and look at the indication and see which indication best suits for that compound. So for instance, like ibogaine, I don't really call it a psychedelic. It's more of a neurogenic, dreamlike producing state of consciousness. Could be really well suited for PTSD or traumatic brain injury. Psilocybin for major depressive disorder, or I'd even argue for neurodegenerative disorders like Parkinson's or dementia. And then lastly, I think LSD, unfortunately, it's so long that it's just not, I guess, revenue friendly having an individual guide and somebody for 10 hours plus. So I think some companies might shy away from LSD or maybe try to create an analog that shortens the trip. But I think the quickest one of all is DMT, dimethyltryptamine. You can find in the mimosa bark, or it's 5-methoxy cousin from our local Sonoran desert toad. I think because the DMT molecules are so short in nature, that might be the best ticket, because it's the time of psychotherapy is so shortened, but the experience, many argue, is exceptionally powerful. And I really believe that the DMT molecules in that DMT family will be some of the best therapeutic molecule medicines for bereavement, going full circle to you have somebody dying, a death in the family. Or I have a friend of mine who is investigating bereavement and different psychoactives. And what drug makes you closer to God or makes you think more about spirituality in the afterlife?
Yeah, I deal with or work with grief every day in my work, which I think of just comes with any kind of change, because there's always a loss, even if there's something you gain. And so when you're having aging, there's micro and macro changes happening. And with brain diseases like Alzheimer's or Parkinson's, there's so much of that. So the ability to step outside of your entrenched, preconceived notions of who you are in the world is especially valuable when you're faced with these kinds of diagnoses. So that could be a space for that to be explored. But I guess I think whenever I think about something works really well, really quickly, it's probably carries higher risks. So for older adults, it might be less appealing. Is that
Maybe
true for
so.
DMT? What do you say?
Yeah, I especially with the safety risks, the thing that comes up to me, especially in the older cohort, would be the cardiovascular risks, as psychedelics could temporarily increase heart rate or blood pressure. Not to mention, and this is something I'm really interested in, is the medication interactions. The beauty of ayahuasca is not only utilizing DMT, but they use the vine from the chacruna vine as an MAOI inhibitor, which elongates the experience. And so my fear is, because geriatric populations have more diseases, and might have a whole pharmacy in their own cupboard. Yeah, I just worry about just uncontrolled cardiovascular diseases.
It's just, it's harder to do those trials, to find the participants that don't have these, and then when you implement this in the real world. So but very promising that there could be other options. And so can you guess what went, as the data continues to be promising and maybe the regulations are softening a bit with the Schedule 1, like what do you predict is going to break through and become accessible and the infrastructure's created well to disseminate this in an accessible way?
Yeah, no, that's an excellent question. So we just recently had a couple months ago the executive order come out to fast track a lot of these psychedelics for breakthrough therapy designation. How I view it is data is king, and it will dictate which substances will pass and which ones will fail. And I really believe that the long-term safety data, and especially in, medically complex patients, we just need better data. And so as more clinical trials are underway and we can look to our neighbors up in Colorado or even Washington to see how some of the more, lax laws surrounding psychedelics occur within the general population, I really think will paint a better picture of how we, look at these psychedelics in a not necessarily recreational term, but in a medicalized setting. And it's so tricky because a lot of my colleagues or individuals that I've spoken with who are self-proclaimed psychonauts all say tripping is better outside in nature, but it's tough. And in the IRB just would not allow any outside tripping.
Wow. Okay. Well, we will see how things will evolve. If you, I think, we're wrapping up. Can you share final words, thoughts, wisdom?
Certainly. For me as a independent researcher, I'm all about public safety. I love studying psychedelics, and I got into this field because I came from addiction medicine as a patient liaison. I saw that the current medicated assisted therapies just wasn't cutting it. And so, not to dig myself too much into the AA system, but Bill Wilson, who created the 12 steps, did LSD and kind of was very intrigued by LSD's effects on alcoholism. But this is what I will say is opening up the medical toolbox when it comes to mental health is imperative. The average American and even worldwide, depression, anxiety, PTSD, is just prominent, and it's very taxing on day-to-day life. And so if we can offer individuals a unique psychotherapy that can make them the individual human flourish, I think we're doing good work. And so my big thing is we need better drug policy, especially when I was growing up, DARE was very big. It's just say no, but in reality, we stigmatize certain substances, and us Americans really glorify alcohol but demonize cigarettes and nicotine, even though there's really interesting research coming out with nicotine as a prophylactic for Parkinson's disease. And so, I don't think drugs in this essentially are morally evil or good. They don't have a conscience. They're just a molecule, a chemical scaffold. And so the behavior associated with taking a drug needs to be studied more as a public safety initiative.
Great. Thank you. So where can people find you, James?
Certainly. So I'm very active on my Instagram and Twitter, or X, now X. It's 5HT2 and James, kind of the play off of
I like it. Yeah. So we'll include that in the show notes, and maybe we can include that paper with the Rebus model, the Robin Carhart.
Yeah.
So they can see the snow globe going around. Wonderful. Well, thank you again for your time, and excited to see how things evolve.
Well, thank you, Dr. Cabral. I really enjoyed our conversation, and thank you for all the work you do. You change people's lives, and
thank you. Thanks, James. All right, listeners. Well, thanks for your time again. This is a really exciting topic. If you're interested in working with us at BrainLove, if you're ever having concerns about brain aging, reach out. Check us out at brainlove.health. See you next time.